Calcaneal apophysitis or Sever's disease is a self-limiting musculoskeletal injury of the paediatric population that accounts for 2 to 16% of presentations to sports clinics. The condition typically affects males between 8 and 15 years of age and females between 8 and 13 years of age before or during peak growth spurts and often shortly after a child begins a new sport or season. It is characterized by enlargement of the epiphyseal line of the ossific nucleus of the calcaneus on radiographic examination, with cloudiness and obliteration of the epiphyseal line. Pain is experienced across the apophyseal area of one or both heels when walking and running during sports. Deep pressure and squeezing the posterior aspect of the heel elicits pain, while toe walking alleviates pain. One proposed etiology is inflammation due to repetitive microtrauma from the pull of the Achilles tendon on the unossified apophysis. Associated pain is believed to resolve once fusion of the calcaneus occurs. The PICO question formulated for this investigation was, what is the most effective conservative intervention, heel wedge, heel cup orthosis, physical therapy and wait and see, for pain reduction and maintenance of physical activity level in paediatric patients with Sever's disease? This PICO question was refined from, what are the most effective conservative interventions for Sever's disease? We refined our question to specify heel wedge, heel cup, physical therapy and wait and see, as these were the most commonly used conservative interventions for Sever's disease. We included the maintenance of physical activity, as this was where we found a major difference in the benefit of conservative therapy as opposed to the wait and see approach. The following databases were utilised: PubMed, CINAHL, Cochrane, Pedro and Medline. The following search terms were employed. Several of these search terms featured the asterisk truncation character to retrieve varying endings of the search term: heel pain and children, orthoses, heel raises, calcaneal apoph, Sever's disease, calcaneal apoph and treat, calcaneal apoph and manage. The most successful search terms were calcaneal apophysitis and physical therapy, which yielded 10 results via PubMed, and calcaneal apophysitis or Sever's and treat and orthoses, which yielded 9 results via PubMed. Within these search results were the studies selected for appraisal. The Pedro scale for randomized controlled trials was employed to appraise the acquired literature. Each paper was awarded a score out of 10 based on research design elements. The first study by Perhamre et al. 2011 was a randomized controlled trial with a Pedro score of 5 out of 10 that investigated the effectiveness of heel cup orthoses and heel wedge inserts in the treatment of Sever's disease. 18 and 17 participants were randomly allocated to the heel wedge insert treatment group and the heel cup orthoses treatment group respectively. The study also consisted of a control group of 5 participants. The primary outcome measure was self-reported pain during activity, assessed via Borg scale. Activity level was assessed via Engstrom's activity index. Participants nominated 2 physical activities, A and B, that induced heel pain, where activity A represented the most painful physical activity. Activities were undertaken at least 3 times per week. Results revealed a significant reduction in pain levels for activities A and B from the pre-treatment phase to the treatment phase with the heel cup orthoses and heel wedge insert, with a p-value of less than 0.001. After discontinuation of treatment, pain returned significantly during both activities when comparing pain levels during the treatment phase to pain levels during the post-treatment phase. P equaled 0.004 and 0.021 respectively. Limitations of this study include a small control group that is not a strict control group, as participants were included separately during a stipulated period. In addition, this study only included male participants, which limits applicability of the study's findings to females suffering from the condition. More importantly, a comparison between the 2 insole alternatives was not provided. Pedro scale points were lost for a lack of baseline comparability, blind subjects, blind therapists, blind assessors, and intention to treat analysis. The second study by Perhamre et al. 2011 was a randomized trial with a Pedro score of 6 out of 10 that investigated the effectiveness of heel cup orthoses compared to heel wedge inserts in the treatment of Sever's disease. This study featured a crossover study design without a control group, where participants then had the choice of which intervention they preferred to continue utilising following the conclusion of the study. The primary outcome measure was self-reported pain during activity, assessed via Borg scale. Activity level was assessed via Engstrom's activity index. Participants nominated 2 physical activities, A and B, that induced heel pain, where activity A represented the most painful physical activity. Activities were undertaken at least 3 times per week. The results revealed that pain levels were significantly lower in the heel cup orthosis group compared to the heel wedge insert group for activity A, with a p-value of less than 0.001, and B, with a p-value of less than 0.001. This was also observed at a 1-year follow-up. Limitations of this study include a lack of statistical analysis for results obtained during the 1-year follow-up questionnaire. In addition, participants may have grown out of the heel cup orthoses by the time of the 1-year follow-up, and this may have impacted the reporting healing of the injury. Also, participants may have chosen the heel cup orthoses based on ease of accommodation within footwear compared to the heel wedge alternative. It is also worth noting that this study only included male participants. Pedro scale points were lost for a lack of blinding subjects, blinding therapists, blinding assessors, and also for a lack of intention to treat analysis. The third study by Perhamre et al. 2012 was a randomized trial with a Pedro score of 4 out of 10 that investigated the effectiveness of heel cup orthoses compared to no intervention in the treatment of Sever's disease. This study also incorporated a matched control group for the heel cup intervention group. Outcome measures focused on heel pad thickness when standing, barefoot with no heel cup orthoses, shod with no heel cup orthoses, and shod with heel cup orthoses. It also focused on maximal peak pressure during running and standing, shod with no heel cup orthoses, and shod with heel cup orthoses. An additional outcome measure was self-reported pain during activity, assessed via Borg scale. Activity level was assessed via Enstrom's activity index. Participants nominated 2 physical activities, A and B, that induced heel pain, where activity A represented the most painful physical activity. These were undertaken at least 3 times per week. Results indicated that heel pad thickness was significantly increased by 2.19 millimeters when wearing a sports shoe without a heel cup orthoses compared to standing barefoot with a p-value of less than 0.001. The addition of heel cup orthoses further increased this by 1.43 millimeters, where p equaled 0.002. A sports shoe with a heel cup orthoses increased heel pad thickness significantly, 3.57 millimeters, compared to standing barefoot with a p-value of less than 0.001. In addition, the heel cup orthoses combined with a sports shoe reduced maximal peak pressure by 21% when running. The addition of the heel cup orthoses to a sports shoe also reduced maximal peak pressure by 25% when standing. No statistical analysis was provided for the impact of the heel cup orthoses on maximal peak pressures. A corresponding reduction in pain during activities A and B in the treatment group from beginning to week 4 from 2.0 to 0.5 on Borg's 10-point scale accompanied these main findings. Significant immediate reduction in self-reported pain continued through to follow-up at 4 weeks. Limitations included a lack of concealed allocation, baseline comparability, blinding of subjects, blinding of therapists, blinding of assessors, and a lack of intention to treat analysis. In addition, the peak pressure test sample group was small, with only 10 participants. Furthermore, staff error with one radiograph meant that one result was missing. Damage to the F-scanner sensor meant that another result was missing. And sensor errors for one child during the final running trial with a heel cup orthoses meant that this child's result was deleted. The fourth study by Wiedering et al. 2015 was a randomized trial with a Pedro score of 8 out of 10 that investigated the effectiveness of a heel wedge, physical therapy in the form of eccentric calf strengthening, and wait and see, or rest, in the treatment of Sever's disease. The primary outcome measure for this study was Face's pain scale revised for pressure pain. The secondary outcome measures included patient satisfaction score on a VAS scale where 0 millimeters equals very dissatisfied and where 100 millimeters equals very satisfied. An additional secondary outcome measure was the Oxford Ankle and Foot Questionnaire, which is a self-reported subjective well-being survey. The results revealed a statistically significant reduction in all outcome measures, where P was less than 0.005 across all intervention groups. However, no statistical significance was observed between the intervention groups at the final follow-up. The only statistically significant difference between groups was patient satisfaction, according to the VAS, in the heel wedge group at 6 weeks, where P equaled 0.01 and 0.001 for physical therapy group and the wait and see group, respectively. The 6-week VAS results were 70, 80, and 70 for wait and see, heel wedge, and physical therapy, respectively. The major limitation of the study was the single-blinded design of the study that did not allow for blinding of the subjects or therapists. An additional limitation included a lack of known compliance of the home physical therapy sessions and avoidance of painful activity in the wait and see group. The main body of evidence suggests that heel cup orthoses and heel wedge inserts within footwear are the most beneficial therapies in reducing self-reported pain during physical activity experienced by pediatric patients suffering from Sever's disease. There is also some evidence to support relative rest as an intervention for this condition. However, this may not be a desirable treatment option for a patient, particularly those who compete within their sport at a high level. Physical therapy has also been demonstrated to provide some benefit in reducing pain while activity levels are maintained. There is a paucity of evidence surrounding the use of taping or strapping, stretching and cryotherapy, making it really difficult to recommend these therapeutic modalities as sole interventions. Several randomized controlled trials demonstrate that heel cup orthoses and heel wedge inserts are beneficial in reducing pain whilst continuing high-level physical activity. In particular, heel cups have demonstrated to be more effective in reducing pain when compared to heel wedge inserts. The literature highlights two dominant etiologies for Sever's disease. These involve displacement of the heel pad, which reduces cushioning and increases impact forces upon the calcaneus during heel strike, and increased traction and strain of the Achilles tendon at the calcaneal apophysis. The use of heel cup orthoses aims to maintain heel pad thickness and reduce pronatory malalignment. This has been proposed to reduce repeated impact and traction forces to the calcaneus and Achilles tendon. The use of a heel wedge aims to reduce excessive strain on the Achilles tendon at the calcaneal apophysis by bringing the ground to the heel. Heel cups which demonstrated efficacy were rigid thermoplastic cups molded directly to the patient's heel. Evidence surrounding use of a heel wedge is based on the use of prefabricated 5mm wedges. When applying this intervention to clinical practice, the patient's specific biomechanical variables would need to be considered, for example, the available degree of ankle joint dorsiflexion, meaning that heel wedge height may vary from patient to patient in order to provide symptomatic relief. Another important consideration when determining the most appropriate therapy is the patient's preference for and satisfaction with the recommended intervention. This may vary. For example, the study conducted by Wiegernick et al. 2015 found that patients reported greater satisfaction with the use of a heel wedge as opposed to rest or physical therapy. The study by Pahamre et al. 2011 showed a trend for patient preference of the heel cup over a heel wedge due to a significant reduction in pain during activity. Based on the appraised evidence, a recommended approach to the management of Sever's disease would include determining the patient's preference for continuation of activity versus rest. Level of competition will likely contribute to this. If patient preference is rest, then a corrective device may not be required. Determining the patient preferences regarding cost and likely compliance with adjunct interventions is also important. If cost is not an issue, the ideal intervention would be a customized heel cup orthosis. If cost is a limiting factor, a heel wedge insert is also a viable option. However, patients are to be advised that this device may not provide as much symptomatic relief as heel cup orthoses. If the patient wishes to continue exercise and cannot tolerate the aforementioned devices, another viable option is implementing a physical therapy regime consisting of eccentric calf strengthening exercises. If the patient is highly motivated, the use of adjunct methods of management that are lacking in evidence, though theoretically may provide additional benefit in pain relief, may also be indicated. These include cryotherapy, taping, and stretching.